anything.
I was hanging upside down from the swing, spinning with the rope broke, and I fell and hit my head. Barely got my arms up. It was like 7 or 8.
So if we had a whiplash or cervical compression, there could be injured ligaments or muscles in the neck, right? So we would probably look at that whole cervical protocol for central nervous system.
If they're not going to remember, like half the time my clients don't even remember their surgeries.
You have a good point, because I was working on a NASCAR race guy in Canada. And he said, by the way, I crashed my car one time and I had 137 stitches in my head. Does that count? Because it was 20 years ago. Yeah, it counts. For God's sake. Good luck doing craniosacral therapy.
Or the soma.
So they all count. So we're going to come back to that. We're going to come back to that, because what I want to show you is any scars are going to limit any outcomes right now. Then if we go back and treat those and do the same technique, the changes of the ATP, the cellular makeup of that scar, is changed at a cellular level, so then it's going to change the assessments of treatments. So one of the things I do, we'll come back to the NPS, is I check lines of tension. I'm just going to pick this leg up and I'm just going to, real gentle, and I'm going to have you scoot down so you're not on the headrest. I'm going to scoot down this way. So what I want them to see, Brian, is what's happening in the whole body, especially extension and flexion of the neck on this assessment of the ankle. So one of the things I do is I just, you know, if you were doing questions?
Request, actually, since you're going to be that end, he's far enough away so we can actually see the neck. Can Doc adjust his face cover? Because we really can't see how.
You'll be able to see his head moving.
Okay.
The biggest thing is his head moving. So when I do this, there's very little movement of the head in there. So you should be able to see this one. So there's something going on. So the next thing I'm going to do is I'm going to do external rotation, and I'm going to just check the lines of tension in the hip. He's good on counterclockwise rotation. He has no internal rotation. So there's a capsular pattern of the hip. So whatever's happening is kind of stopping here. So I'm just going to check. And again, see how that foot can't medially rotate? So if I go into circumduction and medial rotation, you can feel it in the capsules of the hip. So what I'm going to do is I'm going to start clearing the core, the hip capsule. Even though it might be coming from the foot, I'm going to hit all the joints, so it doesn't matter which order I treat. So if you look at this, internal rotation is restricted to 10 degrees with a hard, so that is either a capsular lesion and or secondary muscle guarding, or a surgical scar or non-surgical scar.
No surgery.
So no surgeries. So this should be easy then, right? If we just apply 5 ounces of pressure at the restriction and a little bit of rocking, and then we stretch the capsule, then we go to the next restriction and about 5 ounces of pressure, which means enough to not move the ilium, just to relax the capsule, and a little bit of rocking, and then stretch the capsule, and then to the next rotation. We're almost at 45 now. Now, what's my goal with that technique was to get 60 and 45, but we're only at 30, so I'm going to treat it one more time.
I was a guinea pig in chiropractic college.
You're a guinea pig.
We all were.
You ran around like a hamster on the wheel. So there we go. Now we got 45. So we have good. The femur is moving independent of the ilium. Once you get that clear, move on. Don't treat anything that doesn't have a problem. He doesn't have a problem going external, but he has a problem going internal. So the line of tension is the fact that the femur is going to pull the ilium unless I relax the capsule. Relax the secondary muscle guarding, and then stretch the capsule. They go to the next line of tension, relax the capsule. I want you to notice how hard I'm working. Relax the individual and stretch the capsule. And now the femur is moving independent of the ilium. I can clear that. Then I want to get the ilium moving with those few millimeters of motion that they should have around the sacrum, because when I assess his, you can come overhead like you're in my eyes. He's got an interior right. Number one, his pelvis is rotated this way, so I'm going to rotate him back this way to help with rotoscoliosis of the lumbar spine. Line of tension. And he's still slight interior right, so I'm going to Out flare the iliums, in flare the iliums, out flare, in flare. Push in on my hands with me. Take your hands on the outside of mine and push in, and then rotate. Now we have those few millimeters of motion, and I'm going to go and correct the right rotation, and I'm going to rotate them back to the left to get rid of rotoscoliosis. What's going on with the knee? Right, you want to shoot that from the foot ahead for me. So the foot's turned out. You can only do one technique. What is it going to be? You're going to get rid of what? External tibial torsion. Which hamstring? Short head of biceps femoris. Get some blood flow going in there. Work short head of biceps femoris. Brian, can you come down for a second? So here's what we got. The tibia is rotated out so the patella is tracking. The ligaments are twisted. The bursa is going to be irritated. Short head of biceps femoris is right in here. And then we do the correction. Turn your foot out towards me. 5, 4, 3, 2, 1. And there it goes. There's no more tibial torsion now. So, yeah, no more rotation. What's going on at the ankle? Hard infill. Is that a joint problem or a muscle problem?
Joint.
What if you're in a stretching class and I say, stretch his gastrocs? You're like, but Jim, I can't. Then don't stretch the gastrocs because your assessment told you not to. What the assessment's telling me, we'll get there.
Yeah.
So if I go everywhere he wants me to go, then I'm going to be off my. I'm going to lose focus. So I'm going to go for the whole body, and I will go to this leg next. But what holds bones together?
Ligaments.
And when I compress the joint together in neutral, what am I doing to the ligaments?
Relaxing them.
What's that called? If you want to sound smart, it's called positional release of the
Articular ligaments.
If you want to sound smart, but maybe you don't. But I do. Positional release of the articular ligaments, which reduces secondary muscle guarding because it turns off articular ligament referral pain patterns, which allows me to take the talus and the calcaneus, and the decompression of talus means I can increase plantarflexion and dorsiflexion. If I traction the calcaneus, I can increase inversion and eversion. So the joint function now is better. And let's go to this side. His foot's turned out. Let's see that from the head of the foot. Where's it coming from? Hip or knee?
Knee.
How do you know that without
No, yeah.
assessment? If you go back to the assessment based on neuroplasticity and muscle memory, some of it's coming from the hip. Well, not really. Most of it's coming from the knee. So short-handed biceps femoris. Turn the foot out towards me. 5, 4. That's fatiguing. Short-handed biceps femoris. Relax. This one, he needs an anterior posterior glide of the fibular head, which I threw in with correction of the tibial torsion, and then he's got a hard infill. He has a hard infill on eversion, and he has a hard infill on dorsiflexion, which means that he's sprained this ankle.
Jammed in head-on collision.
Jammed it in a head-on collision, so there's compression of the articular cartilage, but there's also a lateral shear of the talus. Again, positional release of the articular ligaments is just relax the ligaments, which turns off articular ligament referral pain patterns and reduces secondary muscle guarding, allowing me to decompress the ankle. There, the talus is moved posterior and medial now, dorsiflex your foot because you can see the difference, feel how soft it is. Now we have good dorsiflexion, good. So just checking through lines of tension in the ankle, knee, hip, shoulder, elbow, wrist, and neck. They're all affecting that left shoulder. And by now he'd say, but can you work? No, I can't work that shoulder. But they want you to, right? Mm-hmm. In fact, we're not going to do that shoulder until we do the dolphin neurostim and the occlusion strapping of cryoderm on that shoulder. So he's going to get the full gamut of what's in the movie. But on this shoulder, he's got impingement. This shoulder, this is his left side. We don't want to work that shoulder. You see what would happen if he even tried to do it with the mildest of assessment. However, his right shoulder.
Exercise is detrimental now?
Yes, sir.
They are. Okay.
Yeah, that little thing you were doing with the ball the other time. When I was stirring it up, I was going to wait till this week to tell you. I'd like to get to know you better before I beat you. Right?
2 months.
I won't pick on you till after I get to know you better, but since we got to know each other really good last time. So he's been doing exercises without getting that shoulder healthy enough to perform. So that's my opinion on some manual therapy practitioners. a lot. So what we're going to do here is we've got impingement because there's a springy block anchor. Now I'm going to do three simple things to clear it. I'm going to check that hard infill, which is right there, and I'm going to relax the capsule. And I'm going to relax him because he's guarded, especially since that was uncomfortable. I upregulated sympathetic stress. And then I'm going to stretch the capsule. You can bring the camera up a little higher to get to see my wings. Thanks, Brian. And then stretch the capsule. There, that just cleared out. Now watch his external rotation. We should have good inflation.
Wow.
But in order to stretch pec minor, if I went to stretch pec minor like many of you would, his eyeballs are going to get big because you're jamming the impinged supraspinatus tendon. So if you back off and do the middle deltoid work, like some of you learned when we did the shoulder work, and you just drop the humeral head. You feel that humeral head dropping? That dropped really nicely. So there must not be a scar between it and the acromion in that supraspinatus. Once you drop the humeral head, you can stretch pec minor, which is this muscle right here, and that allows us to increase abduction and external rotation of that shoulder. Elbow. Hard infill. Should I stretch predator teres if there's a hard infill on supination? What holds the bones together?
Ligaments.
Ligaments. When I compress the joint, it's called positional release of the articular ligaments. You might want to get that word down, makes you sound smart. And the rocking reduces secondary muscle guarding, especially with all the other stresses in our world right now. Gentle rocking calms down the nervous system. Try it over. Then what you do is you stretch the ligaments that hold the radial ulnar bone to the humerus to allow better extension, flexion, pronation, and soft infills on supination. Move on to the wrist. It should go into radial ulnar deviation, flexion, and extension. He's got a limited extension pattern. So we're going to go ahead and relax what holds the bones together.
Ligaments.
What is called what? When I
Positional release of the articular ligaments.
Sounds smart. And then we do a distraction, which is called arthrokinetics, and then we prove joint function. I'm just going to do a little assessment here. There it goes. And now extend your wrist back. Good flexion, good extension, good radial. And then integrate. Calm down the nervous system. Just make everything be connected. This one, we're going to wait because this is the chief complaint. But I am going to do one thing. Do you get any numbness, tingling, paresthesia, pins and needles?
Not a lot, but this pain.
I'm just going to get that clavicle up off that first rib a little bit. Just going to pull that clavicle up off that first rib. I'm also just going to get a little bit of an increase of space between the first rib and the clavicle to free up a little bit of the brachioplex of the nerves. But I'm going to leave that shoulder alone because we're going to treat everything else and come back to it. However, the elbow feeds the shoulder and the wrist feeds the elbow, so let me check joint function of the elbow. It should flex. It does. It should extend fully back to 0. It does. It should pronate 90. It does. It should supinate more than 60, shouldn't it? Hard infill. This is a joint problem. A joint problem means relaxed ligaments. Ligaments hold joints together. Don't worry about somebody that says you're mobilizing joints or adjusting joints. You're not. You're relaxing ligaments. And you're relaxing guarding. And then you're stretching the articular ligaments, which means you can increase supination, pronation, flexion, extension patterns. This one, he's right. This is more involved. So stretching the soft tissues is counterproductive to a joint problem. What holds the joints together is the articular ligaments, so relax them. Radial bone, ulnar bone, metacarpals, carpal bones, shorten all those ligaments. Then do arthrokinetics to distract the secondary muscle guarding due to articular ligament stress, then stretch the ligaments, and now let's reassess good flexion. Where do you feel that right there? So let's do this right here. I'm just going to create some joint space. Good joint space, and we go into radial ulnar there, just move. Now we can extend. Did I adjust him? No, you didn't see him do any form of high velocity maneuver. The reason that carpal bone moved to stop jamming the radial ulnar bones as I did positional release of the articular ligaments. And then I just calm down a little bit. Now, OA joint problems, going to shoot right about where I'm standing. Flex his head and neck and assess range of motion on left rotation. That's it. That's good range of motion, right? 30 and a hard infill. Now, what if he was in the stretching class? Would that stretching do him more harm or good?
Harm.
You can't stretch because it's the bony compression. You can't stretch. All I'm going to do to correct that is I'm going to go into the curve of the neck. I'm going to traction into that cervical curve and decompress the neck. So into the curve of the neck and decompress with my whole body. Good shot. And then I'm going to get under the occiput. And on the front bone, you can look down to the eyes. I'm going to stretch those suboccipitals in neutral, in left rotation, and in that was right rotation and in left rotation. So if I just get a curve in the neck and decompress, and I stretch the suboccipitals, and now rotate as far as you can to the left, you get a lot better range of motion just from those two techniques. He does need posterior facet joint closure, he does need lateral closure of the facet joints, so we could step in and do this, but for now we're going to move on. We're going to go prone. I just want to do some quick and easy things under license. Okay.
Cradle.
When they're prone, if I step back, wow, is that good?
No.
He has a right iliosacral obstacle. Good luck treating a shoulder when the hips are this uneven. Good luck treating the shoulder when the hips are this uneven. Either has an anatomical leg length difference or iliosacral upslip, but this appears to be a right iliosacral upslip and unlevel sacral base. There's spring in this ilium, but there's nothing in this one. So if I don't treat that through positional release of the articular ligaments, we'll shoot from the head. So by outflaring the ilium, you're relaxing the ligaments around the sacrum, and with 10% of your strength used, you're going to do just this move right here. You're just going to do a right hip hike when I ask you to. Go ahead and do a right hip hike. 5, 4, 3, 2, 1. Then I outflare it and decompress. There, we just moved. Reassess. Feel the difference in the positions? You guys see the difference?
Yeah.
So that means that I can then treat that. This is really cool for decompressing lumbar rotation, really good for scoliosis for lumbar. You can work it all the way up into the thoracics. It's movement of the iliums around the sacrum. You do that on both sides because he's rotated. You see that? This is what I wanted you to see. What do you see? What does he have? One of the iliums is rotated anterior around the sacrum. It's called an iliosacral torsion. So this one is deeper in the table. So if I go under this side, I can get my hand under there just fine, but I can't get under this side because it's rotated into the table. So push your left ilium in the table for 5 seconds, relax. And then when you can relax, I get rid of the torsion. Then I just decompress the lumbar segments up into the cervical mobilization stuff. Then we'll go to the next. That's better. Shoot from the head for a second, come back around this way. This is back. It's so fast that frontal cortex and that neuroplasticity takes things to those patterns. Which hamstring is it? Short head and biceps femoris. Now rotate your foot out towards me and relax. There it goes. Now I'm happy. This is moving better. This joint's moving better. This tibia is lined up. I can move on. It's all affecting the kinetic chain. This one's really a lot. You see that? There's no way I'm going to be able to bend his knee past 90 degrees. Do you feel how springy that is? It's due to a tibial torsion pattern. I didn't fully correct supinal or the brain just wanted to go back to its old pattern when he flipped over. Turn your foot out towards me. 5, 4, 3, 2, 1. Relax. There it goes. Good movement of the fibular head. Good movement here. Good lining here. And feel the difference on your knee flexion. You guys see it? Difference. Ankles moving okay. Then I'm going to go back to the shoulder. His shoulders are very rounded. His scapulas are winging. He's got tight pec minor and clavicular rib problems. So it was his left shoulder that's the problem. I can do this on the left shoulder, but I'm not going to do it. I'm going to stretch pec minor from underneath. I'm just going to come under and stretch pec minor. 1, 2, and then get that to relax. 1, 2. I'm going to work that middle deltoid and drop that humeral head. You see how that gets rid of bursitis and shoulder impingement, and is going to help me when I treat the neck. Again, pec minor, finger pads are like that. Stretch 1, 2, work that middle deltoid. Can't say enough about middle deltoid and dropping the humeral head. That humeral head's dropping nicely. No more bursitis on this right side. No more impingement. No more TOS if I can get good clavicular rib patterns. Okay. Let's go face up and finish up the Lewis system. Now, if you scoot back down so you're off that neck piece, just face up. And now watch his head move when I do this. There's better movement through the pelvis, into the shoulders, through the hips. There's less restriction on circumduction and internal and external rotation of the hips. There's better movement of the through the whole kinetic chain of the body. And now I can get better movement in the neck. I treated those rounded shoulders that had. And so do you see how that's going to affect he's not rotated in his torso. He's not rotated in either the shoulders or the neck. They're kind of even. So now I can go in and assess that shoulder. Just doing that. Can you stand up for a second? I haven't treated what he came in for yet. That's tomorrow. Tomorrow we're going to do the occlusion strapping, the dolphin neural stem. Tomorrow we're going to do all the shoulder stuff. But I want to assess the shoulder we worked on. So we worked on the right side. Flexion should be good. So good external rotation, 5 ounces of pressure to stretch it. If we relax the capsule and stretch that capsule again, I should be able to easily stretch out pec minor. Oh yeah, much easier to stretch out pec minor. And then I shouldn't have any shoulder impingement. If I just work the lats now, that's the soft tissue piece. So let's check the one. Look at his feet. Just don't move. See, he's used to being where he was before he got on this table, isn't he? Frontal cortex, neuroplasticity, old memories. Can you straighten your feet up? Because it shouldn't hurt. It shouldn't hurt your knees or your hips. Straighten that left one in a little bit more. Now, pretend that you're going to sit down, because it would have hurt your knees to do this earlier. Sit in that chair slowly. Just do a squat while you're sitting down. You feel a difference in your knee patterns? When these two bones are lined up and that foot's not overpronating or supinating, then sitting in a chair is going to be so much easier. Normally,
I felt like my hips were going to pop last night.
let's do a jumping squat. See how your hips feel. You still could activate the glutes, couldn't we? Any problem? Would he have more power if I activated the glutes coming up into the jump? Absolutely. Would it help his back? Yeah, because we would turn down the firing patterns of the muscles. We would turn down QLs. So a lot of things we could do. So let's just check the shoulder that we didn't work on. We didn't work on the left side. So turn this way. Let's check your degree of flexion. Still, it's better. So did I say I was going to fix him, or did I say I would improve the quality?
Improve the quality.
But I am going to treat that shoulder after I do the occlusion strapping and the dolphin neural stem. After I do that, I'm going to treat that shoulder. What about your degrees of external rotation? Still a little bit of a guarded response, but do you see how much softer it is? It's a lot better range of motion. So a lot of that was secondary muscle guarding due to all the kinetic chain patterns affecting his shoulder. Plus, when he was rotated like that, his shoulder is different than when he's not rotated like that. So the idea is that fact that these joints can move better and this can move better, this is already moving better, isn't it? So this is going to be a piece of cake now once I do the microcurrent around the shoulder for any scar tissue, and I do the occlusion to totally turn off any relationship to pain, because he did have pain when I first assessed it. So we're going to stop right there, and we're going to treat your shoulder later after we do the occlusion strapping and with the crowder, and we do the microcurrent protocol that's in the video. So now walk up and down this. The only thing I want you to do is act cooler. Don't walk like a zombie. Do some cross pattern. Do some cross. Let the arms move more freely. Let the arms move more. They're supposed to. When you're a little baby, your arms are cool, synchronizing with your knees. So if he doesn't do it this way, we'll get him on the floor. We'll have him crawl on all fours till he learns to crawl again, and then we'll get him back up walking. He's still guarded. He's still. Just deep breath, relax. Now let your arms swing a little bit more. When you walk, it should be a natural cross pattern. Opposite leg, opposite arm, natural cross pattern. And that it takes a load off your back. So teach him to walk again. He
still guards his left leg.
He still has a lot. Yeah. So he's still guarding his left leg, did you say?
Yes.
You know why? He still has a little bit of, look at how his foot's turned out when he walks. Can you turn your foot in so that when you're walking, they're straight? Now he's not guarding his left leg anymore, because we took out
But
the tibia.
he stopped his cross movement as far as his arms.
I know,
It's just relearning balance.
he is. After my hip replacement, I didn't cross pattern for 6 months, and my wife said, you need to learn to walk again. You need to learn that, like when this was here, I couldn't flex this leg at all the last time I was here. But I'm learning, I'm telling my brain it's okay, telling my brain it's safe. Because a lot of these patterns for most of their life has been, you do this, it's going to equal pain. So they've been learning to compensate for that. Thank you, you can have a seat. Any questions on just that quick checklist of joint function? Mostly I looked at joint function. Because if the joints aren't functioning, it doesn't matter what you do with the muscles, you can't balance. So kind of mixing in joint function with Dalton and ambrosia, and then there's the horizontal diaphragms, which is pretty astute. That's what works best for my wife's low back pain, is the horizontal diaphragms. I do recommend taking Kerry Ambrosia's online. He's got a lot of stuff online right now too.
Yeah, just the same.
Any questions? Okay. What I'm going to do next is a 6-minute review of what we're going to do on his shoulder tomorrow, and then we'll learn